Okay, I'm sure we'll have some stragglers. This is a tough time of day. Everybody needed their caffeine infusion after sitting in a windowless room. So thank you guys for sticking with us. We have 2 more presentations in this part of the symposium, and then we hope that you will join us for the poster session at 4:30 in Finestone, because although I've been really excited about this set of talks so far, and hopefully you have been, it's really through one sort of lens of designs. It doesn't showcase all of the different kinds of research that are happening here at the school and other parts of Baltimore that have to do with autism and public health. So that poster session will give you that much larger view. So please join us for that. But moving through our perspectives today that went from large national registries through HMO-based kinds of projects and case-based registries. Now we're going to shift gears a little bit and think in a slightly different perspective. Again, how you can use data, and in this case administrative data that may come from private insurance, and Dr. McGinty knows a lot about public insurance as well. But what we can learn about that, both in terms of etiology, but I would shift your perspective a little bit to think also about what it informs us about services and policy. And so we're very fortunate to have a team of folks in the Department of Health Policy and Management here in the School of Public Health who are interested in mental health services and policy, and specifically folks who are thinking about how this overlaps with autism and developmental disabilities. And so I'm very happy to have the privilege of introducing Dr. Beth McGinty, who is in HPNM here. Welcome.
I was just making sure I knew how to advance the slides. Hi everyone, thanks so much for being here and for having me. I'm going to start with the caveat that unlike all of the previous speakers, the majority of my research is not on autism, and I don't consider myself an autism expert at all. The study that I'm going to talk about specifically is the first study that I have done on autism, so sort of bear that in mind. That said, the reason that I was asked to be here is that I do lots of studies using insurance claims data, both public and private. The study I'm going to talk most about uses private, but in my sort of introductory slides, I'll talk about claims data in general and how we might do autism research with it. So I'm going to hit on 3 main points in my talk. Just a big picture introduction, as I just said, to insurance claims data. How we might use private insurance claims data in particular in autism research. And then I'll give you an example of a study that's actually led by Liz Stewart and Colleen Berry, who is a collaborator in my department in health policy and management, is also on the paper, on the effects of the federal mental health and addiction parity law on service use and spending for autism in kids with autism ages 0 to 18. So what is insurance claims data? So this is billing data. This is not data that is collected principally for epidemiologic research or health services research. It is collected for billing purposes. And as you will see, that really shapes what this data looks like and what you can do with it. It is like bread and butter data that I use in my world all the time of health services and econ work because it includes cost data. And there are various sources of claims data for different insured populations. Every insured population has an insurance claims database. So some common ones, public payers, Medicaid, Medicare, the Veterans Health Administration. You see those used in research very frequently. Private payers, people will do research using data from individual health plans like Aetna, aggregated groups of health plan data like HCCI, the Healthcare Cost Institute data, and the one I'm going to talk about today, which is MarketScan, and I'll tell you a bit more about what MarketScan looks like. And I'll just stop for a minute and flag for the Hopkins students in the room. These private insurance databases usually cost a lot of money to get access to and therefore are not very good for students to work with. But you have access through the Department of Mental Health and the Department of Health Policy and Management to this MarketScan data, 3 years of MarketScan data for free. And so if that's something you're interested in, like, follow up with me. All right, so like what types of information is included in claims? The Data sources that you've heard about so far today have a wealth of individual information about their risk factors across sort of a whole variety of domains. And the information included in claims data is much more limited. So what you tend to get in a typical insurance claims data set is some basic enrollee information, and I mean basic. Age, sex, and usually some kind of geography. Might be region, depending on the data set, you might go down to zip code. Does not usually have race or ethnicity, with some exceptions. In Medicaid data, you sometimes get it. And it doesn't have other information on like socioeconomic status, family income, housing status, none of that. Okay? You'll get some basic provider information. So your database here is full of claims, and a claim is just a indicator that a service happened. It's a bill, basically, right? Service X happened and it cost this much money. And on that claim, you'll have some information about who provided the service. Was it a primary care doctor? Was it a psychiatrist? So on and so forth. And then you will have information on that claim about utilization. So you can figure out the number of services that a person got. Say you're interested in mental health services in kids with autism. There will be an individual identifier, and you can figure out how many mental health services that kid got. You can look at types of services. So what is the diagnosis code on a given claim, a bill, and we can tell then that that service had something to do with autism or depression or the flu, as the case may be. There are also procedure codes, which can tell you things like, was this a visit for medication management or psychotherapy or occupational therapy or speech and language therapy? It's just a code. Okay? And you'll usually have some information about dates. When did this service happen? And if it's an inpatient service, when were they admitted and when were they discharged? And then, as I said, one of the main motivations for using this data is that there is information about the cost of the services provided. And so you'll usually have information about the total cost of a given service. Let's say it's a primary care visit. How much did that cost both the insurer and the patient? And then in some data sets, it depends on the claims data, it will break down what was the cost to the insurer, how much did the insurer pay for that, and how much did the patient pay for that out of pocket through like a copay or a deductible or co-insurance, right? The key to remember there is that we only see the out-of-pocket amount that is run through the insurance system as a copay, a co-insurance, or a deductible. We don't see any services for which people paid entirely out of pocket, and we don't see balanced billing, like if a doctor bills a patient above and beyond what they bill insurance. We don't see that in these databases. So what kind of outcomes do we measure using claims data? So I've listed the 4 most common categories of outcomes that we measure with insurance claims. So we look at the prevalence of service use in a given population. So for example, what proportion of kids with autism used any mental health service in 2012? Note that I am saying prevalence of service use. This is not a data source that allows you to estimate prevalence, even for your restrained insured population here, because all we are seeing is the services used, and a lot of kids in this who are actually insured by your given insurance plan might not be getting services, or they might be getting services and those services aren't paid for by the insurer. They might be getting their services in the school instead, for example, or the insurer might just say, no, we're not covering that, and then it never comes up in your database. Right? So there are some limitations there. We look at the frequency of service use in a given population. So for example, it was the average number of outpatient mental health visits among kids with autism in 2012 or whatever time period. We look at cost. What was the average total cost for mental health services among kids with autism in X health plan in 2012? And you can separate that by insurer costs and out-of-pocket costs. And then another very common metric that we do with these claims databases is quality. So there are a whole bunch of sort of nationally accepted claims-based quality metrics, some of which are better than others, and which are increasingly tied to payment. So for example, health plan, we're going to measure your quality of depression care using claims data, which generally has to do with if a person has a diagnosis, did they get follow-up in this period of time or something like that. And insurers have to show that they are in fact, or excuse me, doctors and insurers have to show that they are in fact doing that, in order to be paid. So it's a big deal. So key strengths of claims data. I've sort of highlighted some weaknesses. So why do we actually use this? So it's longitudinal. It is a very large sample size in most cases, so you've got lots of statistical power. As I said, cost data. Depending upon the payer or the conglomeration of payers, like in the MarketScan database I'm about to talk about, it captures large segments of the insured US population. And so about half of Americans, a little more than half, are covered by private insurance. It gives you complete utilization data for beneficiaries and isn't subject to recall bias. So this is one of the best ways of figuring out what services people actually got and when they got them. If you ask them, when was the last time you saw your primary care doctor? I don't know, like maybe it was about a year ago, right? We can tell exactly when that was using this type of data. And it can be increasingly linked to other data sources with other strengths. So we see a lot of examples in the literature. I'm not going to go into this in detail, although I'm happy to talk about it, where we're doing a much better job sort of linking claims data with, for example, national survey data or national vital statistics data. All right, so thinking about what we can do with this kind of data and autism research in particular. So there are some issues to consider before you even think about what research questions might we answer with private insurance claims data. And I'm sort of framing this now in terms of private insurance because that's the example that I'm going to use, but you could substitute private insurance with X public insurer here, and these issues would sort of still say. So many children and adults with autism are not covered by private insurance, although this looks not that much different than the distribution of insurers in the general population. So about 50% have at least some private insurance coverage. 33% are on Medicaid or CHIP. CHIP is the program for low-income families that don't quite meet the Medicaid cutoff. 18% have dual public-private, so that typically means that one of their parents has employer-sponsored health insurance, and so the child has some dependent coverage through them, but then for whatever reason, state laws have a lot to do with this, they also have probably some Medicaid coverage is the most frequent one. And about 3%, a small proportion, much smaller than in the general US population, of kids with autism are uninsured. Okay. So a big problem when thinking about autism research in particular in regard to insurance claims data is that many children with autism receive services in schools, which are not billed to private or, for that matter, public insurance, right? So it's unlikely that in the kid population, we are capturing sort of the complete clinical picture of what services these kids are getting in a claims database. They're probably getting some screening services in schools. They might be getting some of their therapy at schools. There's a whole host of things that could be happening in schools, which are not going to be captured in private insurance claims data or any claims data. In some sort of small instances, schools are starting to bill those services to Medicaid, but it's still pretty rare. And so sort of just to drive that point home, we are not getting school-based services, we're not getting other non-covered services that the insurer isn't paying for, and we're not getting those sort of 100% out of pocket. We couldn't find another way to pay for this, so we just paid for it, services. Okay. So that should give you a pretty clear idea of the types of questions that we can't answer with private insurance claims data, right? So we can't answer questions about service use or cost in the total US population with autism, partly because we are only looking at a subset of privately insured people in the example that I'm about to give, partly because we're not getting all those school-based services. There's a whole host of reasons. We can't, as I just said, get the complete clinical picture about medical services received by people with autism. We can't get information about health outcomes among people with autism. We don't have biomarker data in here. We don't have things like HbA1c to see how many people have diabetes. The one exception to this is that in some cases you can get laboratory claims that link onto these other claims. You can get laboratory results, that link onto the other claims, and you can get some of that data. There's no information about health behavior included in this type of data. and there's very little information about sort of individual and family level characteristics. So what types of questions can we answer with private insurance claims data? So we can look at questions related to service receipt through private insurance. Again, we know about 50% of kids with autism have private insurance. And so it's pretty important to know what services are they getting that's actually paid for by insurance. Do those services align with the evidence-based services that they should be getting or not? Questions about cost, what proportion of, for example, total insurer and out-of-pocket spending on all kids with mental illness goes to kids with autism. It's high. And then what I'm going to focus on in the example that I'm about to give is questions related to policy changes that influence private insurers. So for example, and this is the research question that I'm going to move us into on the next slide, is how did implementation of the federal mental health and addiction parity law influence mental health service use and spending among privately insured kids with autism? Okay, so this is a study, as I said, led by Liz Stewart. It's not published yet. It's about to go out under review. And it is a study of the Mental Health and Addiction Equity Act. This is a law that was passed in 2008. It went into effect in 2010. It's a federal law. It applies to all private insurers in the US. And it requires that they cover behavioral health services, both mental health and addiction, at, quote, parity with medical and surgical services. And what parity means is at an equal level. And so in practice, what this means is that insurers have to have the same level of cost sharing, visit and day limits, and I'll talk about the non-quantitative treatment limits in a minute, for mental health services as they do for like general medical services. So they can't say, oh, you're having a mental health doctor's visit, your copay is $30, but you're having a visit for your diabetes, your copay is $10, right? And this, prior to this law, was something that happened pretty frequently. These services were covered at unequal levels. I won't go into the rationale for why, but if you have questions, I'm happy to tell you. And then one of the really interesting things that this law does is say that in addition to those like clear quantifiable differences in things like copays or annual visit limits, we are also going to say that you have to treat general medical services and behavioral health services the same way for a lot of the sort of qualitative things that you do in providing these services. So a really good example of what that means is prior authorization. So for a lot of insurers, for them to pay for the service, a doctor has to like essentially call up and say, like, this person needs this service, and the insurer says, oh, okay, well, we'll review it. Like, that's not something we pay for without review. And they'll review it, and they might come back and say, no, we're not paying for that unless you try A, B, and C first, right? And historically, that kind of prior authorization has been much more common for mental health and addiction than it has been for other types of medical and surgical services, okay? So the reason that looking at this law in the context of autism is particularly interesting is that there's been a lot of controversy surrounding which diagnoses parity covers. So the law specifies parity for diagnoses, quote, under the terms of the health plan. It doesn't have a list that says you must cover services for X, Y, and Z diagnoses at parity. And so there have been a lot of questions about whether autism applies. Does parity apply to autism, or was this meant for things like depression and schizophrenia and not autism, right? And there have been like lawsuits sort of going on around this issue. So we did a study to try to answer this question of whether parity has been making any difference in provision of mental health services for kids with autism. So the primary research questions were among our group of privately insured kids ages 0 to 18, and again, I'll tell you more about that population in a minute. How did implementation of federal parity influence the probability of mental health service use, the volume of services that they received, and spending on mental health services? We then also had a secondary set of research questions, which are really those same 3 research questions, but instead of looking at probability of use, volume, and spending, for mental health services, we looked at what we called functional services, which are defined as speech language and occupational and physical therapy services. And these are services that parity does not directly affect. But the hypothesis was that, well, if PARITY does what it's supposed to do and it gets more kids with autism into mental health services that are covered by private insurance, there might be a spillover effect where their doctors are referring them to more of these functional services that might also get covered by private insurance than we saw before. So we used this MarketScan commercial claims database. So what is this? This is a large, convenient sample. It's owned by Truven Healthcare Analytics of beneficiaries and their dependents from large self-insured employers. So these are the big employers in the United States that essentially take on the risk of the insurance themselves. There are people in this data set from all 50 states in the US, but it is a convenient sample. It's not nationally representative. The trick that sort of made this study work is that as a result of these beneficiaries being a part of large self-insured firms, people in these health plans were not subject to the state parity laws prior to federal law. There is sort of this tricky exemption under a law called ERISA that said, okay, you know, all you states, and it was a lot of them, over 30, that implemented laws parity laws at the state level, those did not apply to people who worked for self-insured firms, right? So everybody in our data set is subject to the parity law, which turned out to be almost 50,000 kids, ages 0 to 18. We required that they have 12-month continuous enrollment. So for each year they were in the sample, they had to be in for all 12 months. And they had to have autism, which we defined as having one or more primary diagnoses of autism, which we used based on that ICD-9 diagnosis code on a claim during the study period. Okay, the measures line up directly with the research questions that I just talked about, so I'm not going to go through every single one of them. And we did what was honestly a pretty simple interrupted time series analysis. We did not have a comparison group, which is a big weakness, where we looked at trends in measures pre and post implementation of federal parity using interrupted time series and some techniques to deal with the autocorrelation in the data. So what did we find? So frankly, I think we were all a little bit surprised by these findings, and that our hypothesis going in was that parity might not have done much for kids with autism for some of the reasons that I described. However, we found significant effects in essentially hypothesis consistent directions of what we would expect the parity law to do more broadly. So we saw that parity resulted in increased use of both mental health and functional services. So that spillover hypothesis that I talked about is supported by the findings. We saw increased volume of mental health and functional service use among kids with autism following the parity law. Increased total spending, which we would expect, more services equals more spending, but no effects on out-of-pocket spending on mental health and functional services, right? So after parity, kids with autism were getting more services, but their families were not paying more money out of pocket. If they had gotten the same amount of services pre and post parity, we actually would have seen those out-of-pocket costs go down. So some key limitations here that, again, are sort of meant to bring home some of the limitations of claims data for autism research more generally. We were unable to assess the medical and functional services that these kids received, which weren't reimbursed by private insurance. And again, school-based is probably particularly problematic. We couldn't assess out-of-pocket costs associated with balanced billing, which insurers do particularly for like high-cost intensive outpatient treatments, where in addition to getting money from the insurer, they will separately bill the patient and say, we sort of need more money from you. We had no comparison group. And then it's very difficult with claims data to disentangle which services were used to treat autism versus comorbid mental health conditions, right? So we saw high comorbidity of mental health conditions, as you've heard from other speakers, anxiety, ADHD, depression, others, in this group. And with claims data, all you have is sort of a row of data that is a billing claim, and it's got a primary diagnosis and some secondary diagnoses, right? And in theory, the primary diagnosis is the reason for the service, but in practice, it's entirely possible that a claim that had autism as a primary diagnosis and ADHD as a secondary diagnosis was really an ADHD service, opposed to something going more directly at autism, and we really can't tell the difference, which is why we looked at mental health services as a big bucket. And in conclusion, from this study, the federal PARITY law increased the likelihood of using mental health and functional services among kids with autism, and it increased the quantity of services used and total spending on those services, but these changes did not lead to higher family out-of-pocket insurance costs, which is a summary of what I told you before. This is, I think, particularly important given some changes in the policy landscape. For example, the California law that we just saw, private insurers are increasingly covering autism services, and while the federal PARITY law does not require that insurers cover mental health services, like there's no requirement that they cover autism or depression or anything specific. Under the Affordable Care Act, both mental health and addiction are essential health benefits, which means that insurers in the health insurance marketplace and under the Medicaid expansion and in several other sort of insurance buckets in the world now have to cover these types of services, which means I suspect we'll see an uptick in coverage of autism. And I'll stop there.
Questions? Yep. And you might have said this in the beginning and I might have missed it, but with the claims data, if a claim is submitted but rejected, does it appear in the file?
Repeat the question.
Yeah, so the question was, if a claim is submitted but then rejected by the insurer, is it shown in the file? So the answer is it depends, and it can be hard to tell. So the way this would look if it shows up in the file is that you'll essentially have a duplicate claim, where a claim comes in and let's say the dollar amount on the claim is they wanted $55 for it. And then you'll have another claim like right next to it with hopefully the same sort of visit ID number or person ID number that has negative 55 on it. This is no, we're voiding this out, we're not paying for it. But in some cases, again, it's gonna depend on the insurer and it's gonna depend sort of what happens on the data processing side before researchers get it. You don't see that at all. So it's not reliable enough that I would ever say I can quantify what exactly was rejected. For sure. So what we did was a very straightforward and pretty inclusive strategy. So we had 6 years in our study period, and we said that if a kid during this period has both 12-month continuous enrollment in a given year, they had to be enrolled, so they had enough data for us to look at them over time, and any primary autism diagnosis across those whole 6 years, we are including them in the sample. And the rationale for that is that a child may not be diagnosed with autism until they're 3, but we are going to assume that they had autism when they're 2, right? And they may not use services when they're 4 for whatever reason, but they're still in our sample. So the biggest concern with this is it's potentially inclusive, right? We are basing this on a single diagnosis, and we know that diagnoses might change over time. They're initially given a diagnosis of autism, but then 6 months later they see a specialist and that goes away. So the way that we would most commonly look at this and what we did in this paper is to say, well, let's be more restrictive and let's restrict it, for example, to kids who had 2 primary diagnoses. You could sort of keep going with more than that. When we required it to be 2, the sample size goes down some, of course, but we didn't see any substantive changes in our results. And so we kept the more inclusive definition on the larger sample size. Yeah.
There's another, yeah.
David, yeah.
There's a big debate between the mandate advocates and the PARITY advocates, where the mandates list very specific services, usually with one state exception, about what has to be covered. And the mandate folks argue that in order for people to get the quantity of care that's normally indicated for kids with autism, you have to really specify, because PARITY isn't gonna, it might get more kids into the system, more kids, but it's not gonna get them the quantity of care that they need. And on the other hand, PARITY is in some ways much more expansive and open to much more interpretation. And so if PARITY works, you don't paint yourself into the corner that the mandates may do by insurance companies saying, oh, we're only going to pay for this very limited set of services because of autism. And I was wondering if you were able to look at whether the quantity of care, and I know you don't have education data, and I don't, lots of stuff you don't have, but are you able to look at I know you saw a statistically significant difference in quantity, but is it a clinically meaningful difference in quantity? Do you see these kids getting a lot more therapy than they were pre-PARITY?
Yes. Well, so I'm not, oh, sorry. So the question was about quantity of services, and do we see a clinically meaningful, in addition to statistically meaningful, sort of increase in the number of services that kids are receiving? So I'm not a clinician, so I'll sort of punt whether it's clinically meaningful to those who are in the room. But what we saw was, and this number may be off by 1 or 2 because I'm doing this from memory, but it was about a 12 outpatient visit increase on average per year.
Oh.
In the year after PARITY, wasn't it? Did you just look at it?
I'm playing with the paper.
Okay, maybe I'm wrong. Maybe it was 12 across the entire period. Liz is pulling the paper.
Sorry.
I
I thought it was like 1 per year.
Order of magnitude.
1 for over
Oh.
1 year was 1.5.
So you know what where that difference is? So the 1.5 is among where the denominator, exactly, where the denominator is all kids, right? So across all the kids who used any services in that year, the average is, or across all kids who were in the study sample, whether or not they used services that year, 1. The 12 was if you make it conditional on the kids who use services
Among
in
those
that
who use
year.
services, it's about 1 visit per month more that they're getting.
Among all the kids, including those who, yes, correct, the ones who use service about 1 visit per month more. But that's not the number that we report in the paper. We report it among both users and non-users.
I would
Yeah.
report the other one too. I think that other one is a really
We
critical
debated on
number.
that.
We debated. Yeah, but I think the point about the sort of the mandates, just more broadly, the mandates sort of versus PARITY is a little bit silly. I don't think it's necessarily one or the other. You need both of them. But I think that what the mandates do that's really important that PARITY doesn't do is lay out some of those services. So one of the big problems that we see with PARITY in general is that there often aren't good medical surgical equivalents for some of the types of services that we need in the behavioral health world, right? Like ABA is a perfect example. And in like more of my work is on serious mental illness, intensive outpatient treatment or partial hospitalization. Like there aren't very good examples of these things on the medical surgical side. So how plans are supposed to apply PARITY is very unclear and the source of a lot of consternation and lawsuits.
That was sort of my question as well, because with copays, you might pay $10 for a regular general practitioner and $20 for a specialist. And so if they're supposed to be equal, it's based upon what equivalence?
Yes,
Is it a specialist or is it a general?
So in that scenario, it in most cases is going to be a specialist. A psychiatrist is going to be on the specialist range. And same thing for like the in-network, out-of-network is a big issue with mental health in general, and I suspect autism as well, and that there often aren't enough of the providers that you need, the specialists that you need in your network, and so you need to go out of network, and their PARITY would apply. You have to be equal with out-of-network medical general services and out-of-network behavioral health services.
Great, thank you.
Thanks.